Welcome everybody again to the next monthly installation of the AI Journal Club. Today we're going to be talking about PreciseBreast PDxBR. This is a new model that is actually really came out in 2022. We're going to discuss 3 of the papers that have been published for this specific model, including the development as well as the validation. Let's start with the clinical problem. So for breast cancer, the Nottingham grading system evaluates breast cancer aggressiveness specifically by scoring 3 histologic features. This is tubular formation, nuclear pleomorphism, and mitotic activity. Grade is an independent predictor of both breast cancer-specific survival as well as disease-free survival in early-stage breast cancer. The Nottingham grading system has a reported 25 to 30% interpathologist discordance, especially within grade 2. And one of the major drivers of that discordance is the mitotic figure activity. And for those of us who have worked at the VA, you sometimes realize that up to 50% of pathology reports in the real world are missing key elements that are pertinent to the patient's treatment and management in the future. So the main clinical gap that this model is really trying to address is that many early stage patients fall into this intermediate grade 2 that may appear ambiguous specifically to the pathologist. So the population that this model is really intending to focus on is early stage invasive breast cancer, specifically hormone positive, HER2 negative. Below you can kind of see a really visual representation of the histologic slides. On the left side, you can clearly see that there's more defined tubular as well as lobular structures of the breast cancer tissue itself. And as you move towards the right, you slowly start to see the really breakdown of that morphology as well as really pretty significant change of how the cells themselves look, as well as the nucleus and the overall organization of the cells. So just a quick 101 for breast cancer, specifically for early stage breast cancer. You split it up into 3 categories: hormone positive, HER2 positive, and triple negative breast cancer. We further characterize the hormone positive breast cancer by 3 specific features. The first one is the gene expression. We use Oncotype at Georgetown, but there's also MammaPrint. The histology that incorporates the Nottingham grade. There's elements also like proliferation rate, Ki67, and hormone positivity. And the clinical features is the TNM staging, the menopause status, and the genetics. Now we consider all of these 3 factors when we're really deciding what is the best next treatment for the patient. And the treatments that we have are chemotherapy, surgery, radiation, hormone therapy, and CDK4/6 inhibitors. So this is a basic overview of how early stage breast cancer is treated and some of the tools that we have to intervene with as a clinician. So what is this model? What is PDxBR? And what is the goal? The goal is to standardize breast cancer grading and provide a tool to predict breast cancer recurrence within 6 years. The model overview and what it actually does is that it's an AI model that analyzes H&E slides to quantify tumor biology. It combines morphology and clinical features together, and it produces a recurrence-based interpretable risk model. How is it specifically made? It's made by a supervised multimodal AI model. I'm going to explain what that means in a minute. Some of the key design choices that were intentionally made by this specific model in this company is that it measures the established tumor characteristics first. It then predicts the risk second. So it's sequential in that manner. And why is this important? Because it really can provide a layer of explainability or interpretability for the physician. It avoids a black box pixel to risk model. And it also preserves the biologic interpretability, just like I was mentioning. So what are the inputs for this specific model? What do you put into it, and what does it consider? It does the H&E whole slide images. It also incorporates the clinical feature. So what does it consider? The age, the tumor size, the AJCC stage, so TN and M, and the nodal status. What model does it actually use? It uses a supervised CNN, convolutional neural network, for object detection. It incorporates feature engineering specifically to the morphology that is desired or identified. And there's an element of fusion with the clinical data that happens later on in the actual model. And once it has those two elements combined together, it uses something called SVR, which is a linear model that is called a support vector regression survival model. And what does it output? It's a continuous recurrence risk score from 0 to 100. And I think that this is what's pretty important of the model itself. You just look at the inputs, look at the model, and look what it's outputting. And what does it give you? It gives you a continuous recurrence risk score, and they split that up into high risk and low risk. They set that cutoff at 58. So this is going to be an overview of the slide. You can see the star on the top right, so you can, refer back to it if anyone wants to look at it later. So how did they train the model and how did they validate it? So they trained it in 2022 in the United States, and they used around 2,000 patients for the model development and internal validation. They trained it on 1,500 and they validated it on 500. Okay, so this is the internal validation that they used within their own cohort. And you can kind of look at the characteristics of the population that they used themselves. And you notice something pretty interesting up front. The first thing is that they didn't only include hormone positive disease, they actually included some HER2 positive diseases, up to 13% in the training population, 11% in the validation cohort. They also included not a huge amount, but there is a fairly large amount of lymph node positive disease. 1 to 3 here on the bottom, you can see here, was about 15% for the training and similarly 15% for the validation. The grades, there was a pretty good breakdown from all of the grades from grade 1 to grade 3 itself. And then you can also look at the total events. Now, you don't expect every patient in this population to actually have an event because recurrence is defined as, local or distant metastasis or overall or death, meaning those are the specific endpoints they would have to meet to qualify towards those events. And for early stage breast cancer, the prognosis is generally speaking excellent. So here's a model overview again. The first step in the model itself is to use artificial intelligence to analyze the histology. Then there's specific histologic features extracted from those slides itself. Those features are combined with the clinical data, and it provides a survival-based risk regression. And it's the continuous recurrence risk score from 0 to 100, stratified from high and low. I just want to repeat this so that everyone understands the model quite clearly. Here's a diagram of basically how they developed it. They started with the slides, they added the features and the building blocks, and then they outputted a risk stratification. Now let's go down into some of the more details of the model itself. I'm going to be really focusing on just the key aspects that I think are important to look at, especially for clinicians. The first part is how do they go from a slide to something that a machine can actually analyze? And that's what they used in image analysis layer. And that's where the CNN comes into play. CNN is convolutional neural network, and it was trained on pathologist annotated data. This is important because it's not as if these are latent embeddings. So what does that mean? It means that the model is not just identifying features themselves. It's using predefined characteristics that are defined by the pathologists. And it's learning from the pathologist's annotated slides. It's looking for tumor nuclei, the mitotic figures, the tubules, the glands, the tumor infiltrating lymphocytes, and those are the key features that it was looking for. The CNNs do object detection. It is not involved with the outcome prediction. And really the intent is to try to make this interpretable and explainable. Those are the main elements that are going to be the recurrent theme for this specific model. Now we go to the feature engineering, and this is why this is not actually a black box model itself. So once the CNNs have detected the objects within the model, it quantifies them. It specifically looks at the proliferation, the nuclear pleomorphism, the tubule formation, the tumor architecture, and the immune infiltration. It's explicit, it's named features that are aligned with histologic grading concepts that we currently use. And the intent of this is to really parallels, something similar to what we saw in Tempus TO. There's something that is very explainable that you can track back to specific elements to attribute the risk. After they have done this, they did something called feature selection and multimodal fusion. So, they had about 800 individual image features, and they filtered that down to a small prognostic set. So they went from 800 just down to 7. So those are the 7 elements that are going to be contributing to the actual risk itself. And the selection was based on outcome relevance and redundancy. Some of those 800 features were redundant themselves. After they did that, they fused that with the clinical data, like we talked about before. Those variables include age, the TNM, the lymph node status, and the size. And the intent of this aspect was to not just throw all 800 features and get a random score that you can't attribute to one or the other, but something that can actually be traced back to one of these 7 features in regards to how much it contributes to the risk itself. And that's where the risk model comes into play. This is a survival-aware support vector regression, SVRC. The key properties of this is that it's weighted, it's linear, and it's interpretable. Each feature contributes additively. Just like Tempus TO, you can clearly see that if it has this feature at this rate or at this value, then it adds to the risk of recurrence. It handles censored follow-up. Again, this is important because a lot of patients did not meet the event that was of interest. That's going to be breast cancer recurrence or death. And the output of this risk model is risk for any type of recurrence or death. The intent of this is that, clinicians need to understand why a specific patient was classified at risk, at high risk. And here's an example of some of the features that were contributing to a higher risk pattern. The ones on the left were some of the weighted contributions to the model. The regional lymph nodes on the left showed that it was a high risk of recurrence. The nuclear pleomorphism was another example. Age, proliferation, stage, and gland were all considered to be contributing to a higher risk, whereas those that are considered to be of lower risk of recurrence are the infiltrating lymphocytes and the gland feature that was labeled as 4. So now that we understand how this model was actually built, we got to see, does it work, and does the model do what we intended it to do? Meaning, does it accomplish the goal that we set out from the beginning? And the way that we measure what the model is actually doing and if it's doing what we think it's doing is discriminating between high and low risk patients. So they use something called a C index. A C index basically is a means of discriminating between high and low risk. And what it found or what it did or what it outputs is a numerical value of 0 to 1 where 0.5 would be a 50-50 shot, and the higher the number that goes, the better the model's able to distinguish between those who are at high risk and those at low. So the model training set was 0.78. The validation was 0.75. And so what this means in basic terms is that the model correctly ranks recurrent risk in approximately 75% of patient pairs. And on the right side here, you can actually take a look at something that we're much more familiar with, which is actually the Kaplan-Meier curve for those who are at higher risk versus lower risk in the time to the event of interest. And that's where we talk about the clinical risk separation. So not only did we separate it accurately, but what did the clinical risk actually look like? And they did this in several different ways. The first step is that they took the model itself, they looked at it, they measured itself against itself, meaning the high versus the low. And what they found is that they were able to find a hazard ratio of 5.5 with a clinically significant confidence interval as well. The validation cohort was 4.4. So what do I mean by training and validation cohort? Remember, training is where is the population of 1,500 in which they actually built the model. Once it's set and finalized, they ran it on the validation set. And so it's no longer training on the validation set. The model is set, and this is just what they're seeing, how well the model performs on that 500 patient population. They separated this a little bit more, meaning that they looked at the AI image grade versus the physician-assisted histologic grade. So if you remember, the PDxBR is a combination of clinical features and the AI image grade. But if you do the AI image grade alone and compare it to the physician-assigned histologic grade, you still have a pretty significant hazard ratio of 3.65. And that is consistent with the validation cohort as well, meaning that really this model is able to determine, or it basically outperforms the reported histology risk. So that's the key takeaway of this slide, is that combining AI features, or the AI with the clinical features, provides the strongest prognostic performance. And that's what the model actually is. Now, interestingly, they also reported the negative predictive value and the positive predictive value. And I think everybody who practices in breast cancer knows that the threshold for detecting those people that are high risk is very high, meaning that we don't want to miss anybody who might potentially benefit from a therapy. We will treat a lot of patients to receive a small amount of gain, meaning that a small amount of patients will benefit. Even we are willing to treat a lot of patients for a small amount of people to be benefited. And so the negative predictive value was 0.95 in the training and 0.94 in the validation. The positive predictive value was 0.32 and 0.24. Again, these are low values because not everybody did, in fact, reach that event of interest. Another consideration in this specific model is that they looked at Oncotype recurrence score and they combined it with the PDxBR. So on this model itself, they looked at Oncotype itself that had a very low C-index of 0.35. When you start adding the individual elements to this, you add just the grade, you add the clinical feature, you add the AI grade, and then you add the final model, the PDxBR. You can see sequentially that they improve in their C-index and discrimination. And the best C-index here was the Oncotype with the PDxBR. So that was the first paper in 2022 that focused on the clinical validity of the trial. There was a separate paper published in 2024 that looked at the analytic validity of it. And what did they do? They specifically asked the question, is this test reproducible? Does it work across several different sites? And I really want to switch or really skip over to the interpretation of this slide and this model, because I think that it's very important to just realize that it was highly reproducible across several routine pathology variations, and that the performance was consistent with the clinical assay. And it's not necessarily a fragile AI model. It worked in a variety of different cases with really excellent precision, recall, F1 scores. So this is really a good test that is very resilient. They then took this model after they did the analytical validity and applied it to a completely external population in the Netherlands. And this was published in 2025. They specifically looked at this population and asked the question, does PDxBR generalize across countries and hospitals? And so they took a population of 739. These are hormone positive, HER2 negative early breast cancers. And they did a retrospective analysis with a median follow-up of 8.8 years. And what did they compare? They compared the PDxBR with a clinical risk model built by the authors. They compared that also with an image alone, meaning that the AI grade, and they also compared it to something called the MIND-ACT-like clinical trial model. These are clinical features, clinical prognostic models that are already established, so compared to the PDxBR. And then they also included MammaPrint within this comparison as well. And what did they see? As you can see on the right here, there was a similar C index to what they were seeing within their internal population. The hazard ratio, again, was quite good. It was 3.05, and you can see a clear separation of the curves on the right. The negative predictive value was 0.9, which again is quite good. And the interpretation is that there was modest performance attenuation in the external cohort, which is expected, but it's relatively similar to what they studied in 2022. And it maintains a clinically meaningful risk stratification. It supports real-world generalizability across labs and geography. Importantly, like I mentioned, they did compare MammaPrint with PDxBR, and you can kind of see here that MammaPrint does not really separate those at high risk versus low risk. At least in this cohort, specifically the C index was 0.52 compared to PDxBR, which is 0.71. The last element to this model is that they did a prospective feasibility study. And really the clinical takeaways is that it was cheaper than Oncotype and they could obtain it much faster than Oncotype. It had pretty strong concordance with RS-Clin, which is a combination of the recurrence score and clinical features. And this study was basically only done as a concordance comparator. It's not really an outcome based benchmark, which means they didn't really compare the outcomes of RS-Clin. It just says if it was concordant or not. So as we approach the end here, I want to just kind of do a couple of key points in some of the core messaging of this actual model. So PDxBR is a morphology-based prognostic AI. It does not incorporate genomic or any predictive values. PDxBR uses H&E, not DNA or RNA. It measures tumor architecture, proliferation, and immune context. It quantifies the baseline tumor aggressiveness and is prognostic only. It answers the question how aggressive this tumor is, and it is clinically valid. There's analytic reproducibility, there's external generalizability, and is prospectively feasible. The last element is that it's not a black box model. And that's what a lot of people are afraid of when they see AI. And this is not that. How is this different from Oncotype? Well, look, Oncotype uses gene expression. It is predictive and prognostic. It estimates the benefit of chemotherapy in hormone-positive disease. So it answers the question, will this treatment help this patient? That is not the same thing that PDxBR does. So the takeaway is that they are not the same. It measures baseline biology, not treatment response. So I wanted to stop there, and I want to talk a little bit with everybody in the group about a couple of questions about this model and how you might clinically use this. The first thing is let's say you had a high-risk PDxBR and you had a low-risk Oncotype score. What do you do with that information, if anything? And so in the future, what I suspect this company is going to do is that, this is just a prognostic baseline biology model. I'm very sure they're going to be incorporating a predictive element in it, incorporating the genomics into the actual risk calculator itself. Yeah. And that's clearly going to be their next step. Artera AI already does that for prostate cancer. Mm-hmm. But the question then becomes, would you trust a model like this based upon retrospective studies? Or do you think that something like this or the next step, which is going to be predictive, needs prospective trials? I'll send this out to everybody so that they can review it.